Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you have chosen to spend a few minutes with us. We're going to have a very interesting discussion today with one of our regular presenters. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you, Dr. Neighbor Stevens, Dr. Ivan Walks, and Dr. Hines, and welcome to our special guest today, Dr. Lawson. So we had an interesting several weeks with people making public statements, and I know they've been eating dogs and cats somewhere in Ohio, according to certain people. And I think that's weird. And maybe we will have a meeting one of these weeks on weird people, Dr. Lawson. We'll get, and Dr. Walks will get you to describe what weird really means. We have more and more of them. But
So Dr. Maxey, in the
Yes.
interest of interrupting people and fact checking, which we know is an important thing to do, there is no credible evidence that anyone in Ohio has been eating cats and dogs. So I want to make sure that that's very clear. And I also want to make sure that we always welcome those who are watching and listening on YouTube, in addition to those who are with us on the Zoom meeting.
No, that's great. That's great. But I'm going to ask for, at another time, not now, a psychiatric diagnosis of what the word weird means. And maybe we'll come up with that next week. But today we're going to speak about a topic that's very important, and it's called depression in Black men. I'd like to welcome to the stage Dr. William Lawson, MD, PhD, who's a professor of psychiatry at George Washington University, former head of psychiatry at Howard University and about 10 other universities. And he refused to invite me to have barbecue at his house. One day I'll get there. Dr. Lawson, welcome.
Thank you. And let me see if I can get my screen above to the, oops. How do we go to the slideshow section? Is this showing on the slideshow yet?
We're seeing a slide that has answers. There we go. Depression in African American men.
Right. And I just want I want to also thank you guys for not talking about my cookouts, which we serve bison and occasionally frog legs and rabbit, but we won't go into that. Yes, and as you noted, I'm clinical professor at George Washington University, professor emeritus, dean emeritus at Dell Medical School, and professor emeritus at Howard University. And for a shout out to note that Howard was listed as a top HBCU for the first time in a long time.
Okay.
But we'll go right into the issue and note that I have nothing to disclose, no industry support right now. And I always like to start out with this slide just to give people what we're talking about. And this is the old, the dog says, I got the bowl, the bone, the big yard, and I know I should be happy, but I'm not. And that's what we're talking about, not really having people being down, but not really having any clear-cut reason for why they should be down. So, and that's why depression often is unrecognized, untreated, and a real problem. It is common. It is either self-limiting, sometimes it goes away, or it can be chronic and very severe, and we still don't have a good technology to determine which can do which. It contributes, and I'll make a case that it contributes to morbidity and mortality, that it is an important cause of death. There are biopsychosocial causes, and the important point is that it is treatable. This is just showing you some numbers, 10 to 14 million people depressed in a year. 1 in 8 people may require treatment. And the important thing is that 1 in 10 will attempt suicide. Just note some people who've had depression. Ernest Hemingway, as many know, he did commit suicide and wrote about his depressive episodes. Abraham Lincoln had very severe bouts of depression. Van Gogh, as you know, cut his ear off. whether or not it's from his depression or from his tinnitus, don't know. William Styron wrote extensively of his depression. And also there's now evidence that Martin Luther King had bouts of depression that actually led him to be hospitalized, going in saying he needed to take a rest. Don Cornelius started Soul Train, committed suicide. And there's a lot of politicians, athletes, actors, actresses, public figures who have had severe depression. The important thing is that this is not an uncommon problem or illness. It is very, very common. It's one of the leading causes of disability worldwide. It is common. Unfortunately, it has lousy diagnostic reliability, but it is also, and important for those of you who are in the medical field, one of the most common comorbidities in medicine, but also one of those that we often ignore. It's associated with myocardial infarction. People who have major depression are more likely to die. Also, is heavily associated with diabetes mellitus, and it is common in obesity. And we now recognize that it is a risk factor in breast cancer and perhaps other cancers as well. Depression and physical illness are treated differently and looked at differently. There's the old saying, if physical illnesses were treated like mental illness, well, someone would come up and say, you have food poisoning, but you should at least make an effort to get up, or just got a hand chopped off. Why don't you just change the frame of mind and you feel better? This shows the absurdity of how people react to people who have severe depression versus if the same people had a physical illness, it would be, we would consider the behavior unacceptable. It's a brain disease. That is that it is pretty much the same, irrespective of culture, country. The People's Republic of China tend to show low rates of depression, but what we found out that because of the culture, they don't complain of the subjective experience. They'll say something like they aren't able to work as well as they should. We've had imaging studies showing there are consistent abnormalities. We now have some candidate genes that's been identified, but I'll say more about this. And pharmacotherapy is reliably effective. The genetic risk is, however, is very low. I've been involved with multiple studies of depression, bipolar disorder, schizophrenia, and other psychiatric disorders. And what we quickly, not quickly, after next millions of dollars of money spent on multiple studies, simply have not found found some candidate genes, but no definitive gene associated with depression as we have with other psychiatric disorders. And we think that it, in many ways, is a non-response to other factors. Now, how common is depression? We like to distinguish depression in the sense of major depression, which is what we like to be concerned about medically or clinically, versus it is normal to get sad or down. If you don't get sad or down, then it's another phenomenon we call alexithymia, which is we can consider an illness. So if your mother dies, your best friend dies, you may have a grief reaction. These are usually self-limited and can be treated with good old support. Or situational depression. You go out and a car runs into your house and you smashes your house or you lose your job. It's normal to be down or sad for brief periods of time. Or an adjustment reaction. You move to a new neighborhood, the neighborhood is lousy, the house is lousy, you don't like the place, you may be down for longer periods of time. But again, these are normal reactions to environmental situations. On the other hand, if it persists over most of the time for 2 to 3 weeks, then we start thinking that the person has a major depressive episode. When they have depressed mood, but not necessarily depressed mood, because sadness does not always have to be associated with depression. Common in many cultures, folks don't get sad, but they do show the other signs. Or they just get mean or irritable. Or they just show no emotion at all. They look flat. And you can get changes in weight or appetite. Some people gain weight, some people lose weight. The difference is that the changes are persisting and extreme. You can get changes in sleep. I had patients who said he had gone for several days without sleeping no more than 1 or 2 hours a night. And I was 14 hours, 12 hours, sometimes several days in bed and sleep. It can be associated with agitation, restlessness, or just slow down. It can be associated with what we call easy fatigability, or you just don't have an energy. Often there are feelings, this is heavily culturally related, but there may be feelings that you're worth no good or you feel guilty. And it's not just feeling worth or guilt. You're the worst person in the world, or what you did was inconscionable. Or there may be an inability to think or concentrate. And most importantly, we are very concerned when a person may have thoughts of death or suicide. And again, I just want to note that because this is a potential lethal disorder. Oops. So one of the other things that we just begin to appreciate is that often with major depression, there are physical symptoms. And these can be chronic pain, stomach problems, digestive disorders, or chronic headaches. So there can be these physical symptoms, and they don't respond to the usual treatment. As I said, irritability and restlessness is seen, as well as energy fatigue, feeling slowed down, and loss of interest or pleasure, including sex. And folks who become anorgasmic because of depression. Do minorities get depressed? Is that a dumb question or not? Well, believe it or not, for a long time it was felt that African Americans were too unsophisticated. As we talked in our suicide talk, it felt that African Americans didn't kill themselves, and partially because we didn't get depressed. And this was not just true for African Americans, other groups, Chinese, Eastern European immigrants, all of them, they didn't have depression either. And yet, when we look at what we've been through, slavery, black codes, civil rights era, even today when folks are sometimes harmed or killed by the people who are supposed to be protecting us, we find that there's consistent, ongoing environmental factors that is surprising that folks do not express themselves in some ways, such as depression. And part of the reason, but the argument I'm going to make is this being expressed, is just that folks don't talk about it. And part of it is this incredible stigma. Keep it in the family. If you have a depressed member, you just don't want to talk about it. People will talk. It's not my side of the family, this side. But there's the shame. And we're struggling with working with the religious community, which is both a plus and negative in some ways. The religious beliefs, somehow, if you're depressed, it's because you just don't believe strong enough. And the whole felt that because we went through so much, we are a strong people. And good old African-American resilience, we're strong. If you're not, you have weak stock. And the whole National Mental Health Association survey, unfortunately, is still applicable. The Black Psychiatrists of America, Napoleon Higgins, thinking about redoing it again. But some of the points, unfortunately, from other surveys, so that they're still consistent. More than half of African Americans still feel it's a personal weakness. Only about a third think it's a health problem. I was just in a meeting when someone just came out of the blue and said, this depression thing, this might be a public health issue, which why we've been stated for the last 3 or 4 decades. 30% of people say they can handle it. 20% said only 20% said it would seek for depression seek help for depression from friends and family. Only 1 in 4 recognize that change the eating behavior and sleeping behavior is a sign of depression. People certainly do not recognize irritability as a sign of depression. Only a third said they would take medication. That's changed somewhat. Yes. That changed somewhat in the last couple of years. And again, 2/3 still think that prayer and faith alone will treat depression. So does it exist? Part of it also, especially for our young men, better to be bad than mad. You don't go out and tell your buddies, hey, man, I'm damn sad. They'll think you crazy. Instead, it's good. What a lot of folks do is act out as a way of showing their feelings of depression. It's interpreted as a clear sign of weakness. You will be bullied, and a lot of young men do get bullied. And they'll say you got a little punk in you. Quite a sign that you must be gay, or you got the blues. It's just part of our lifestyle. It's who we are. Then there's John Henryism, the folks that work like demons when they become depressed, who go out, do extra work, do overtime, just work like crazy. They're not energized. That's how they're dealing with those feelings. There's some folks who are saying we're suffering from racial battle fatigue, day-to-day dealings of just being, living in a racist society. And of course, weathering, that Black folks physically, psychologically, may age faster because of the ongoing concerns of racism, social statism, as well as casteism. It's interesting that in part of the problem is that our ancestors from many West African countries, there's not a single word for depression. Guilt is rare and shame is common. I had colleagues who, one lady said, yeah, we don't have it in Nigeria, because another lady said, she's crazy. But also, we find that folks are somaticized more often. They deny, they're irritable, say they're falling out, don't talk about the inner feelings. Some folks say these kinds of feelings are part of our healthy paranoia. And then there's John Henryism, the concept my colleague Nell Prim will tell you about the concept of the angry Black woman, which is becoming an integral part of our culture in some ways. And the idea is inconsistent with African-American resilience, and also is inconsistent with religious beliefs. And because of this, because of the unrecognition of it, we're now facing a new crisis that is the suicide rates are rising faster among people of color than of white individuals. The young African Americans now have suicide rates twice of any other group, and the only other group that's higher is some groups of Native Americans. And related to that, we've seen the death rate from drug overdoses go up. We also saying this, and I think all three of these are interrelated. That in many ways, the drug overdose rates and the suicide rates are related to unrecognized depression expressed in other ways. And depression is also associated not only with comorbidities, physical, but people are seeking self-treatment with recreational or illicit drugs, and it's associated with with violence. A lot of men don't want to go hurt themselves, so they take it out on other people. And what we find is that it is a public health concern. It's misdiagnosed, under-recognized, under-treatment, over-stigmatized, and because of employment challenges like unemployment, poverty, experience of racism, discrimination, would face different barriers towards getting mental health services. Lack of insurance coverage, helped a lot by the Affordable Care Act, but not completely. And many states have who refused to get expanded Medicaid from folks that have absolutely no coverage. I was in Texas and in DC. DC has almost complete coverage. Texas is almost none, and I was just shocked. 20% of the people had nothing at all. Fewer health care providers. I'll say more about that. And also, we've talked previously about how many of our folks just don't trust the medical system. Depression can't just be treated by medication alone. We're working very well that social support can be and we need additional support services other than psychotherapy or medication. So we got a vicious cycle: self-treatment with drugs, increased risk of traumatic experiences, increased risk of mental problems. And also, many of our folks end up in the correctional system. But we find, especially if they are arrested for drug offenses, rather than going into treatment, they go in the correctional system. They're disproportionately in the correctional system. Many jails and prisons have a lot of people who, in fact, are in the correctional system rather than in inpatient psychiatric facilities. And only about 15% get the noted treatment. Good news, treatment does work. That's the great news. And we have to decide whether we're going to treat people or we're going to rehab or punish them for something they can't deal with, that's often not their fault. We have insight-oriented psychotherapy, which worked on the so-so. This guy named Beck found out that if you go and confront people about the irrational thoughts related to depression, you got better results than if you just try to see what the underlying cause of their problems are. So we have we had insight therapy, where we now recognize cognitive behavioral therapy, group therapy. Sometimes you get the whole family involved, or you may even, and we're doing less and less of this in this country, but we should do more, network therapy, reaching out, not just to the individual, not just to the family, but to the community that they work with. And we now have medications that work. This is not to say they work all the time. The effectiveness of medication for depression, pretty much the same as we find as treatment of antibiotics. But unfortunately, we don't have a good technology yet to determine which drugs work for which people when. And most of these drugs have not been studied with patients with comorbidities. Many of our African-American patients, there are all kinds of comorbidities. But the literature is based on people who have one single disease. Behavioral therapy is a cornerstone for many people, but again, it's not been extensively studied in the dual diagnosis. We now have SSRIs, SNRIs, a whole range of agents now that, unlike the old tricyclic antidepressants, don't really have much in the way of persisting side effects. They're incredibly safe. People take them for years with no problem, but they take a while to work. They usually take maybe a week or two. The person who is suicidal, that's a problem. And what we find is that some drugs will work for some folks, but not others. Because of metabolic differences, many African Americans are what we call slow metabolizers. And with the usual drugs that we have on hand, they may have more side effects because we haven't titrated the medication for their needs. And we have other treatments with people who don't respond to anything. Electroconvulsive therapy does work. We now know that light therapy, shining on the right frequency of light to the back of the head, can be as effective as medication. Exercise is effective. Some of the over-the-counter naturalistic drugs, such as St. John's wort or SAMe, do work with minor depression. May not work very well with major, but it works with minor. And we now have transmagnetic stimulation, which you can put a coil around the head that looks like a dentist chair, but it's not as scary. And we found that we get results, maybe not as good as EC, electroconvulsive therapy, but many times as effective as medication therapy. And we also found that, unfortunately, omega-3 fatty acids are wonderful for the heart, but not for the brain. Haven't got good results with that. We found that exercise is great. Spirituality with other treatments can be very effective. And it's not, but we've got to remember that spirituality is not just going to church. It has to be a little more than that. Then some of the newer treatments is ketamine, which is what we call Special K, a drug of abuse. But we found in clinical trials, and I'll say a little bit more about that, it works. Psilocybin, magic mushrooms. Tried to get that approved, did not. It doesn't reduce depression, but there's a risk, there's a benefit-risk ratio in terms of whether or not the person is going to become an abuser. MDMA, again, there's some evidence that works with some individuals, perhaps those with PTSD, but again, there's the risk factor in terms of its abuse potential, and of course, LSD. So we have ketamine, which is a glutamate receptor blocker. I worked with it, very good. Initially, we need to have it infused. Its side effects that can make folks psychotic. Also, folks can abuse it, but it works sometimes immediately to reduce problems like suicidal thoughts. We now have esketamine, which can be delivered nasally, which has been granted FDA approval. But again, there's an abuse potential and said dissociative, psychotic symptoms, and it's got to be taken with regular antidepressants. Other agents that people use, benzodiazepines, do help the anxiety, and they sometimes help depression, but the effects usually tend to be transient, if at all, and also they're associated with worsening mood. Same with marijuana and opiates; they all can improve mood, but still there's a big risk for addiction and dependency. And then we had important to have a cultural overlay, look at where people are in terms of their environment. Psychoeducation is important. Vocational rehab, person been out of work for a long time, getting back to work, sometimes you got to get that vocational. And then we got to have, and then support groups for help. We also find that African Americans tend to have better health outcomes with African American providers. I also did a study showing that white patients did better with African American providers too, but that's another issue. And again, just a reminder that African Americans often seek treatment from other African American providers, Hispanics. But despite this fact of ethnic matching, percentage of doctors have not changed in 120 years, and especially if you want an African American male, it'll be problematic. So we got to get the word out to folks in the community and in politicians and policymakers that is the case. Some reading you might want to look at: Standing in the Shadows, these two classic books. I give my patients Terry Williams' book, Black Pain. Recently, Donna Norris and Nell Prim pulled together a collection of articles that I think are very, very useful in terms of where mental health is today. And I have my own book, which talks about some of these issues, as I discuss the editorials that I've developed to address some of these public health issues. So what we got to do to get on top of this, I think we got to be creative, must not lose our spiritual foundation, got to start knocking out these lemonades out of lemonades out of lemons, and omelets out of broken eggs. Where to get help? Black Psychiatrists of America, Association of Black Psychologists, National Association of Black Social Workers, are all aggressively trying to find ways to reach out to the community. We need to do more to improve the counseling services at our HBCUs, and many of them have gotten the message and begin to develop them. We've certainly got to look at providing services when folks end up in the correctional system, especially before they're actually sentenced in the pre-adjudication programs. Need to provide those services. There are support organizations, all of whom have very low African American membership. National Alliance for Mental Illness, Mental Health Association, Depression Bipolar Support Alliance. These are all organizations that have aggressively now trying to get more African American involvement. But these are volunteer organizations, and patients have other demanding tasks that that often get in the way of getting to meetings and other factors. And we also are working with barbershops and beauty parlors. There's a Confess project, which is begin to try to get mental health services in barbershops. My own church is working with, literally has their own geriatric center in which we can begin to deal with provide a social environment where folks who are elderly and depressed can help. This is Zion Baptist Church in Washington, D.C. And I'm sure our excellent colleague, Dr. Walks, will discuss some of the creative ways his church has done in terms of developing its own mental health programs. So addressing these issues, we need increased awareness, improve access, got to have cultural, sensitive events that resonate with African-American men. We got to have more community outreach, education, and tailored mental health services that can play vital roles.
Dr. Lawson,
Yes.
I'm not even amazed anymore with the breadth of knowledge that you bring to the table. Yeah, it's so great. Let me pose two questions. At next year's National Medical Association, I'm going to propose that one of the plenary sessions be focused on the effect of mental health on cardiology, internal medicine, all the other subspecialties. I don't think we give them enough credit. And I think we need to put that to all the practitioners who think everything is physical. We need to do that. And you brought that up. Number two, there are two forms of music that have gotten great success. And I'm wondering if there's any relationship. One is the country western part where somebody did somebody wrong song. And the other one is the blues, like B.B. King and Bobby Blue Bland. Is there any relationship of those? Are they just cultural phenomenon, or are they related to depression?
You know, some of us think that the music itself stimulates the part of the limbic system that is heavily involved in terms of feelings. I mean, that's shown over and over again. And we used to have in DC at St. Elizabeth Hospital or music therapy, and there's a lot of evidence that various kinds of music provided in proper way can be a way of dealing with depression. Unfortunately, the music industry has not gotten the kind of support that the pharmaceutical industry has in terms of doing the kind of research that's necessary to show if it's a good, reliable way of treating. But I certainly encourage my patients to find that right tune that works for you and go for it. You know, you brought up the whole issue of blues. Is blues antidepressant, or does blues provide another way to get out those feelings so that depression does not worsen? It's a good question. But I offhand, and I don't know if any of our listeners may know, I don't know of any systematic research that's been done to determine if, in fact, blues has long persisting effects in terms of depression. Certainly has acute effects, but long persisting effects, don't know.
Thank you. Dr. Barbara Neighbors-Stephens, this is your topic that you suggested. I'd like your comments.
Well, thank you. And thank you, Dr. Lawson, for addressing a topic, one of several that I think we need to spend time on here at Black Health Trust. And I actually have two questions that I want you to answer, targeting the lay public and family members. The first question is, when is treatment needed? How does the family member or associates recognize that we need to get something done here? And what do family members need to do for a family member that has not been diagnosed and is not under treatment, but they are concerned?
Yeah, I think those are two very excellent questions. And I think part of the reason that question needs to be asked is interesting. We rarely say those in terms of general physical problems. When folks need to be treatment, when it finds that it's persisting, and we sometimes use the 2-week rule, but it could be briefer than that if the person is suicidal. So if the person is making life-threatening statements or threatening other people, sure, treatment is immediate. We need to do it right away. If it's persisting over a couple of weeks, then give serious thought to it. And especially looking at these symptoms that are associated with depression: sleep disturbance, eating disturbance, persistent irritability, persistence, and though for most of us pretty straightforward if someone is sad all the time and tearful, but it's not as clear-cut when a person is just indifferent or doesn't seem to care about anything. The guy who says he doesn't go to work, just sit there in a corner and look at the wall. Again, those are the times when we need to encourage the person. Say, look, we have treatments that can help you. This is not something you can deal with simply by willpower. It's not something you can deal with simply by going and willing it away. When it starts persisting, then we have treatments that are effective in terms of making sure that you can feel more like your normal self. And in terms of family members, absolutely want to get out the word that this is not a sign of a weakness in the family. It's not a sign that the person is out to get the family. It's also not a sign that families should start. Then many people like when they're despondent, especially would like to distance themselves from family members. It's not bad to go up and approach the person where they are and re-engage with them as much as possible. And again, if they really get hurt or distant, then at some point, suggest to the person, some of what you may be experiencing is something you can't handle by yourself. We can get you help for it. Just like you had diabetes, or if you have problems with chronic pain, we can get some treatments that may be effective and does not involve locking you away somewhere.
Thank you. Dr. Ivan Walks.
Thank you, Dr. Maxey. Dr. Lawson, as usual, well done. Just really always impressed with the comprehensiveness of your presentations, Dr. Lawson. So I just want to start off by thanking you for that. I think one of the things that I'd like to hear a little bit more from you is this notion about putting things together that work. Folks, you mentioned that folks will sometimes think that they can just I'm just going to pray about it. I'm just going to exercise. I just need to change my environment. I'm going to go stay with my friends, or I'm going to get out of town for a while, and maybe letting folks know that doing those things all by themselves is not a good solution, but maybe something in combination, maybe the medication in combination with your exercising and going to the gym or what have you. So if you could talk a little bit more about not throwing away what the person may think they're going to do, but maybe combining what they think may help with some of the more professional interventions.
Absolutely. Yeah, I think that's an excellent point. Many of us are like one-trick horses. This work for my buddy, it should work for me. I'm going to do this. If it's not working, maybe I should do a lot more of it. And just going on vacations for some people don't do it. It means that they're just miserable when they're out of town. So that's when you say, well, you worked for other things that worked for you in the past that made you feel better, didn't work. Guess what? There are some other options. It doesn't necessarily have to be medication, but there are other possibilities, other ways of looking at the world with some non-medical treatments. I had a patient who has happened to mention that she just got down in the dumps every winter. I mean, she was just down. And she didn't need medication. We found that we got her a light box. She did wonders. She said it made a new life for me. So those kinds of things can make a difference. A guy who his wife died in the house, but he didn't want to leave the house. He said, well, but we'll see what we can do. But we found with him that this is the routine dose of a common antidepressant made him have a new life. And he began to look at the good things about how their marriage was before she died rather than the bad things. So the important thing to recognize is this literally is more than one way to skin this cat. And we can look at, and I'm not for eating either, and we can look at these as ways of problem solving. I look at depression as it's a common human condition that
Mhm.
through the years and cultures, we've developed different ways of dealing with it, some of which work for some individuals, some of which don't work for the others. And we each have to be our own personal scientists to begin to find what works for us.
Dr. Dustin Hines.
Thank you so much, Dr. Lawson, for this timely discussion. You talked about several kind of presentations along the way, and I was wondering if you could go back a little bit and talk about the relationship between alcohol and tobacco. We talked about drugs, right? But lots of times people don't see themselves connected to, substance abuse drugs, right? In the context of alcohol and tobacco. And the second question is around irritability. Can you give it seems like a really simple word, but again, sometimes people don't connect themselves to that presentation of, frustration, anger, lack of patience. So can you speak a little bit more about that very common presentation that you mentioned?
Yeah, I think a common thing to think is that when we think of depression, a lot of people think you're sad, you're crying, you're down. Well, you don't, not necessarily. And again, for some cultures, we found some like in Swahili, you just, the little translation is you're being sad for no reason, or you're making other people sad. So you fight to not express that. And what happens is that folks just automatically, if something happens that makes them despondent, they don't express it as depression. They clam down, they shut up, or they get mad. They externalize. They say that the people around them is what's causing the problem. They walk around and say the angry black woman syndrome, the nasty dude. What they have in common is that these are individuals who are despondent, and their despondency is being expressed by externalizing those feelings to other people. I feel fine. It's these other people that's messing with me and doing stuff and all kinds of stuff. It's not me. And they deal with it and say, I need to get through the day. Let me go out here and have a couple of drinks. Let me say some drink in the morning, maybe something at night to help me to sleep. And so we have this strong relationship with depression and alcohol. It's a vicious cycle. The drink, it suppresses those feelings, but then at the same time, as the alcohol wears off, it comes back twice as strong. And so they say, got to do more of it. Got to have more of it. Say, man, I heard that your mama died. Yeah, have a fifth. And when you watch the tough man movies on TV, that's exactly how they talk about dealing with depression. Folks say, give me a couple of smokes, smoke some more. And then down the road, when they start developing lung cancer, COPD, and other things, say, oh my gosh, that's not what I used to be. Let me smoke some more. Let me just, and those who work in the VA system have frequency and people to have trachs smoking away. And again, they either are not aware or they're very much aware, but need a benefit risk ratio. I'd much rather feel a little bit better now and run the risk of feeling terrible later, because later is later. I'm dealing with me now. And you mentioned that also the whole chronic pain. Those of us who getting past 50, 60, did a lot of martial arts, ran a lot, wake up in the morning, you have joint pain, knee pain, every kind of pain. And what you find is that if you start thinking about, I can't do what I used to do, start making you feel down, depressed. Let me go and get rid of this pain. And so he goes and take various kinds of agents, analgesics, and then they don't do any good. So let me go get some of that fentanyl. That fentanyl stuff really helps. And the pain goes away, but the person still finds that it's not just the physical pain, it's the psychological pain. And they're still in distress, still have problems, no appetite, still can't sleep. And that leads to that vicious cycle.
Are there any questions in the chat, doctors?
Yeah, I saw one actually, or any of these alternative therapies covered by Medicare. That is a great, wonderful question where we can bring in the politics in terms of all this. A lot of us are still struggling with the whole issue of prior approval. The issue that for myself has come up looking at the antidepressant medications. The antidepressants now are safer and some of them more effective than the ones we had in the past, but and especially for African Americans, but but they can't afford the medications. And so they said, well, we got to have prior approval. Unfortunately, by a person who just barely got out of nursing school. So and so that whole issue of prior approval is, and my colleague Dr. Chapman has done some excellent work showing that it's really not cost effective for the patients themselves, and probably not for the insurance companies as well. And the prior approval again comes up not just newer medications, dosing, as well as new treatments. Any treatment that's less than a couple of years old may be wonderful, can't get it. We've had a lot of problems. We have now treatment for postpartum depression. Many programs simply do not cover it. Trying to get ketamine therapy supported, well, that is a challenge, even though you have clear-cut evidence that the person wants to commit suicide. So we're making some great strides in terms of treatment, but unfortunately, our Medicare, Medicaid systems are simply not very receptive to newer treatments. And for those people who don't have a lot of resources, it's really difficult to get those treatments made available. And again, the Biden and Harris administration recently again attacked the problem of differing criterion for treatment in mental health versus physical illness. And it's still an ongoing issue. That there's too many providers still feel that if they too many insurance providers still feel that they need to restrict treatments for mental health because they think it goes on and it's not cost effective, when in fact the evidence is very strong to the contrary.
Yeah, I know we're going to the top of the hour, but I'd like you to address one more thing. We know that the brain produces certain hormones called endorphins. Is there any relationship between either increased endorphins or low endorphins that have effects on mental health?
Oh, absolutely. Yeah, that's a complex issue because it's not just endorphins, but also several other kinds of compounds. The reason that some of these drugs that we used to call recreational or illicit work is because they work in that system and in those systems. And many of these agents worked on receptors. For instance, there is a cannabinoid receptor in the brain. There is known that there's receptors related to alcohol. Then there's a serotonin receptor, which involves a lot of different compounds. So yeah, the idea is to try to target those that are in fact affected. They had great luck with an agent that worked at the marijuana receptor, but it made people suicidal. So we had to be very careful in terms of how we approach these. And again, the endorphin system is very much what's working when we treat drug abuse. Naltrexone is very effective treatment for alcohol, and I just found it was helpful for a kid that had video game addiction. So these are very important systems. It shows that the classical neurotransmitters are not the only agents that are important in terms of how the brain works.
Well, thank you so much. We're at the top of our hour. So would you like to give us final thoughts, Dr. Lawson, before we go to our co-moderators?
Oh, there was one more question that we didn't get to, and there was a question about from Dr. Gibson on digital therapeutics, and if you could speak a little bit about digital therapeutics.
Digital therapeutics, I'm not going to say much about it because the research is very limited right now. I want to say that it's a very interesting idea. I'd certainly like to learn some more about the whole concept of digital therapeutics, as well as just talking to a colleague of mine, talking about using hologram treatments and others. So there's all kinds of new technologies that are coming out here that I think are going to be very helpful. And we need, but unfortunately, the data is coming out as is skimpy right now. We need to. I'm a big proponent of those of us who come up with these unique treatments, as well as some of our old treatments. Bring them back, do careful studies, and make sure that these treatments can be brought to market and made available for the clinical public.
Okay, well, thank you so much. Any final words, sir?
Yeah, I want to again state that depression is a real, major depression is a real illness. It should be treated. And we shouldn't just wait till a person's suicidal, get ready to kill somebody else. We should do more to make treatments available. We need to do more to inform the public that it is an illness and not just the person's own failure and personal responsibility or something genetic, strictly genetic. And because it is treatable, treating these, we can not only save quality of life, but we can also save lives.
Thank you so much. We appreciate you being with us all the time. Dr. Jocelyn Hines, appreciate you summing up your thoughts for today.
So thank you very much, Dr. Lawson, for speaking specifically to what depression can look like in our community, especially because I think it's more present than we realize, and it's around us, and with the coping skills, with the coping mechanisms that you mentioned, right? Like the alcohol and all of the excuses that we make. So I hope for our audience, as you listen to this presentation that Dr. Lawson gave us, you might see yourself or some of your loved ones in what he was saying and take the next steps towards action. And thank you again for highlighting that there are Black associations for social workers and Black associations for therapists, like psychologists too, so that then we can try to find avenues to connect with people who might have shared lived experience with us.
Thank you, Dr. Hines. Dr. Walks?
I would just like to say yes, and what Dr. Lawson has brought to us today is a very clear presentation about not only what depression is, but how important depression is in our community, how depression is continuing to grow in our community, and I think that there's so much that I would want to say. Let me see if I can just summarize quickly. It is important for us to have these conversations. It's important for us to not try to figure everything out ourselves, right? If I've got a pain someplace, I'm gonna go to the doctor. I'm gonna say, hey, doc, I've got a pain here, and that's what I'm gonna point to. I'm not gonna try to necessarily figure out all the different things that the pain could be. And I think when we look at some of the mental health challenges, we can just look for some sort of dysfunction or some sort of difference. I don't know whether the person is sad or irritable, but I know that they didn't used to be this way a few weeks ago, a month ago. They were going to work every day on time, but now they're going to work late all the time. My kid was getting really good grades in school, and now their grades have changed. And so this understanding that sometimes people can have some dysfunction or some significant change, and we don't have to figure it all out. We know from Dr. Lawson's talk today that there are resources out there that can help us with the figuring it out. We just need to know that we're listening and we're concerned with someone we care about, a loved one, a good friend, a family member, someone in the community who is different now than they were before. So, Dr. Lawson, thank you very much, and I appreciate. I always get invited to your barbecues, and Dr. Maxey is just trying to, he's just trying to be down, but he ain't down yet. So,
Well, thank you, Dr. Walks. Dr. Barbara Neighbor-Stevens.
Thank you again, Dr. Lawson. This is scratching the surface of oil that needs to be lanced. And there were several reasons I wanted us to have this conversation. One was because of the clinical needs that are the unmet clinical needs. But the other reason I wanted us to start talking about this kind of thing is you kind of got into it a little bit towards the end, and that is the whole policy end of it. And that is something that with the mental health parity bill many years ago when it was passed, I thought we were on the track to making great headway on uniting the head to the body. But somewhere along the way, we lost our way. And I'm hoping that going forward, we can put the effort back in and get the leadership and at all levels of government. I'm really big about all levels of government to start meeting the needs of the people, because the needs of the people are not being met.
Thank you, Dr. Neighbor-Stevens. I'm going to go back to a thought that I had at the beginning, and that's the word weird. And we hear people using that. And I think it's oftentimes tragically a way to explain something a way very simple-minded and thinking it may be nothing. But in my opinion, the word weird is being used as a dog whistle with very nefarious meanings that can compromise the credibility of certain minorities that exist in our country. So I wouldn't just blow it off as being weird and discount it, but it's something that can be very dangerous, and we ought to know that what it is, that everybody weird isn't dumb, it's purposeful. And I thank you for joining us today. Thank you, Dr. Lawson, for being our guest. We welcome you back, of course, as many times as we can. Have a great day, everybody. Love you.
Good day,
Thank you.
everyone.